Good evening. I'm psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call here in the Fort Wayne area by dialing 969-2720. Or if you're calling coast to coast, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email I received just this past week. It reads, Dear Dr. Fawver, is it true as we approach older age that it is good for both our physical and mental health to carry a little bit of extra weight? I know a lot of people are rooting for saying yes, but here's the deal. I'm going to try to stay in my lane. I'm a psychiatrist, so I'm going to talk about, particularly from a mental health perspective, of extra fatty tissue. Okay, but first, let me go outside my lane and talk about from an orthopedic standpoint. I've heard orthopedic surgeons say, yeah, a little bit extra weight is okay if you fall, if you have a little bit extra fat cushion. But on the other hand, if you have extra weight from an orthopedic standpoint, you carry more weight on the joints, and for every extra pound of weight you have, it's an extra 6 pounds of pressure on the joints themselves. I've heard that stated over the course of time. Cardiologists, I think, would all say that having the extra weight is not probably good for your heart. And from a psychiatric standpoint, I can tell you that adipose fatty tissues will release inflammatory proteins. Inflammatory proteins can go to the brain and make you feel sluggish, slow down your concentration, make you kind of move a little bit slower. Excessive inflammatory proteins can make you more likely to not enjoy things. We call that symptom and the symptom of anhedonia. But inflammatory proteins will cause you to not have fun and take pleasure in different things. So from a psychiatric standpoint, yeah, having extra fatty tissue is probably not a good idea. Again, going outside my lane, an internal medicine doctor who is treating you, noticing that you might have some recurrent kind of infectious condition, a cardiac condition, a pulmonary condition, where you're sick for a couple weeks on end, yeah, maybe having an extra 5 pounds would be okay, because if you have recurrent medical conditions that episodically cause you to lose weight, having a few extra pounds is okay. But again, going back from a psychiatrist standpoint, extra adipose tissue can be pro-inflammatory, which means that it can give you bad effects on the brain overall. Now, what I certainly recommend for people as they get older is to do some weight training, also known as resistance training. We need to grow our muscles as we get older, because as you get older, you tend to lose muscle mass. And as you lose muscle mass, you typically have less stability in terms of your ability to maintain the stability of your frame. So you have more falls, you aren't able to walk as well, you trip more easily. So we need to maintain muscle mass from a mental health standpoint, because I'm thinking if you fall, you're likely to hit your head, and if you break a hip or break a bone, that's going to incapacitate you in some ways, and that's not good for your mental health either. So from a psychiatric standpoint, I'm often recommending to people, maintain your body weight as much as you can reasonably possibly, but also try to increase your muscle mass, because you tend to lose it as you get older. Do some resistance training, do some weight training. Aerobic exercise is still great, but we really got to focus on the weight training to some degree as we get older. Thanks for your email. Let's go to our next email. Our next email reads, Dear Dr. Fawver, can genetic testing predict what medications a person needs? Genetic testing is something that's been around for about 25 years now, in psychiatry at least, and we've used it over the course of time to help us understand three aspects of a person's well-being. And number one, we try to understand with genetic testing if somebody adequately breaks down folic acid. Folic acid is known as vitamin B9, and vitamin B9 or folic acid needs to break down to its active byproduct for it to work. Now, this is kind of like going to this big football stadium we have down in Indianapolis called Lucas Oil. Lucas Oil Stadium, to get in, you have to go through a turnstile. Then once you get in, you're able to watch the game. Well, the turnstile is like this enzyme that's called MTHFR, methylene tetrahydrofolate reductase. Long word there, but methylene tetrahydrofolate reductase. That's an enzyme that breaks down folic acid to its byproduct called L-methylfolate. So L-methylfolate is what gets inside the stadium or gets inside your brain and actually goes to work. So if you don't have a well-functioning enzyme of MTHFR, you tend to not break down folic acid adequately, and you don't make the type of chemicals you need, such as serotonin, norepinephrine, and dopamine. So what do? You have to replace the folic acid with a supplement of L-methylfolate, 10 or 15 milligrams, depending on what kind of genetic mutation you might be experiencing. So the first reason to do genetic testing, I think, is to determine if you have an L-methylfolate deficiency based on this MTHFR mutation, because that could not only give you difficulty with depression and difficulty with concentration, but it could also increase your likelihood of heart attack and stroke. And if you're a pregnant mom, and you got the baby in the womb, you're more likely to miscarry if you have an MTHFR mutation that's not being supplemented with L-methylfolate. So that's the first reason we'll do genetic testing. The second reason would be to determine how quickly you break down medications. Over 90% of all medications are broken down by certain liver enzymes. We call them cytochrome P450s enzymes, and these particular enzymes break down medications. Some medications are broken down quickly by certain enzymes. Other medications are broken down slowly by certain enzymes, and you need to understand if you're prone to quickly break down a medication, meaning that you need a higher dosage, or if you're prone to more slowly break down certain medications, meaning that you need a lower dosage. So that's one reason that we find genetic testing to be helpful. But a third reason why we'll do genetic testing, and this is often getting misinterpreted, is from a pharmacodynamic standpoint to determine if the medication is right for you from a mechanism of action standpoint. In other words, is the medication going to work for you? Now, we can determine if you need L-methylfolate, we can determine what dosage you might need of the medication, high or low, but we also want to kind of know if it's going to work for you. Now, here's where it gets tricky because these genes are wrapped up in these little histones. And the histones, I used to call them pigs in a blanket, but you know, pigs in a blanket have that nice fluffy pastry on the outside that tastes really good. Then you got the hot dog on the inside. I'd rather compare the genes to a candy bar wrapped in paper, all right? So you got a candy bar that's wrapped in paper. On the outside of the package, on the candy bar, on the package it says the name of the candy and it says the ingredients, but you don't taste and appreciate the attributes of the candy bar until you open up the wrapper and actually taste the candy bar. That's the way our genes are. Our genes are wrapped up in this lining, and they don't express themselves unless you open up that lining. And again, it's kind of like the wrapper on the genes. What opens up the wrapper on the genes? Well, it can be life stresses. It can be things that happened to you in the past. It can be you're exercising or not exercising. It can be smoking. It can be drinking alcohol. All these different factors can open up the wrapper for genes that you have simmering there. They're there, but they might not be expressed unless you have stuff that happens in your life or stuff that you've done. So that's why, for instance, when we talk about medications that affect serotonin, all right, we've got these selective serotonin reuptake inhibitors. And the SSRIs are Prozac, Lexapro, Zoloft, Celexa, Paxil, fluvoxamine, also known as Luvox. These are the SSRIs. The SSRIs don't help people with depression so much if you've had a lot of early childhood trauma. So if you've had a lot of early childhood trauma, you can unwrap the genes that are underlying the mechanism of action for serotonin. If you've had a lot of early childhood trauma, the serotonin medications might not work for you, and it's a predictor for the medications not working for you later on. Now, it's not deterministic. It's not going to say yes or no, they're going to work. It's just that it's a factor that we'll consider. So when we look at genetic testing, we call it the genetic testing probabilistic but not deterministic. In other words, it increases the probability that we're going to be swayed in the right direction in our treatment choices, but it's not going to determine do this, do this, do this. And that's where people often get confused with some genetic testing that's out there. They'll have different proprietary brands on the front page. It just says these are good medications, these are bad medications. It's not that simple. It depends on how you've responded to medications in the past. It depends on what stuff has happened to you in the past. It depends on how your family members have done on various medications. So we have to look at all those different factors and then to add the genetic testing results on top of it, and that will sometimes tip the scales. But one of the biggest factors to predict how somebody's going to do on a medication is simply by asking how a family member has done on a particular medication for similar symptoms as you. So if you've had anxiety and you have family members who have similar types of anxiety, hey, how have they done on medications? Poorly or in a good manner? I mean, have they done have they had poor responses to medications? Have they had good response to medications? We want to know the good and bad in terms of how they've done with past medications, because that's a huge predictor on how somebody's going to do with our medication choices. But genetic testing can be helpful. If it was at no cost, if it was free, I would certainly want to do it on every single person I'd see, but there is a cost prohibitive aspect of it, and it always comes down to, is it worth the cost at this point? We often reserve genetic testing for people who might have failed 2 or 3 different treatments in the past. And we always allow the patient to determine if they choose to accept the cost of the genetic testing based on what it might be for them. Thanks for your email. Let's go to our next email. Our next email reads, we have a third email tonight. It reads, Dear Dr. Fawver, I've been on an antidepressant medication for 3 years, and it's finally working for me. That's fantastic. Is there a symptom that's most likely to predict if you'll get depressed again? In other words, you're saying that you've been on, it sounds like you've been on various other medications over the course of time, and here you're finally feeling well. Well, if you're finally feeling well and you're on your 3rd medication for depression, here's the bad news. You might relapse, and even though your life is good, things might be going well for you. If you previously failed on 2 medications and now you're on a 3rd medication for depression, yeah, there's a chance you might have difficulty with what we call depression relapse within even a year. So what's the biggest predictor for relapse? Based on studies that have been done over the past 25 years, there's one symptom that really predicts if somebody's going to just poop out on their antidepressant. In other words, their antidepressant just seems to quit working. Yeah, the technical term there is poop out. It's also known as tachyphylaxis. It just means the medication is not working anymore. When somebody notices the medication is not working anymore, they just out of the blue start getting more depressed. All those old symptoms come back. Now, if you're doing relatively well, what lingering symptom might predict that you're going to have difficulty with relapse? It's anhedonia. Anhedonia means no fun. An means no. Hedonia means fun. So if you're not able to have fun, if you're not taking pleasure in things, if you're not doing things that are enjoyable, if you're not socializing, if you're not getting out and doing the things you like to do when you're not depressed, that will be a predictor that you will get depressed again. And it's something we're always monitoring. There is a scale now. It's a 14-item scale called the SHAPS, the Snaith-Hamilton Pleasure Scale. It's a 14-item scale, and it's not copyrighted, so it's available for clinicians to use. But the SHAPS is predictive of relapse. If you have over 4 yeses, if you have over 4 symptoms on the SHAPS out of 14, showing that you're not enjoying 4 particular different areas of your life, it can be predictive you're going to relapse into depression. And we watch that SHAPS score, and we always want to see the score go lower and lower and lower as people are getting treated with depression, because the SHAPS score is something we consider. Now, the SHAPS score will look at your ability to enjoy things from a sensory standpoint, from a social standpoint, and from a cognitive standpoint. So it looks at different dimensions of enjoyment in your daily life. So it asks you, do you enjoy smelling the flowers? Do you enjoy a nice sunset? Do you enjoy socializing and receiving a compliment? Simple things like that. But those are predictors that people will either stay well or relapse. And the higher the SHAPS score, the more likely somebody's going to relapse. We have found over the course of time, I mentioned earlier the serotonin medications, but we have found over the course of time, the serotonin medications don't help that much with the SHAPS scores. That serotonin medications might not help that much with being able to enjoy things, especially if you tried a lot of different medications over the course of time. So we're now taking a really good look at what specific medication might really help with that underlying difficulty with enjoyment or pleasure. And the medications we're finding to be most likely to help with that particular symptom will be ketamine, which is being used off-label as an IV medication, has been used without Food and Drug Administration approval for depression for the past 25 years. So ketamine certainly helps with that. S-ketamine, also known as Spravato, which is a nasal spray, is particularly good for the symptom of anhedonia. We have Wellbutrin, which is a medication that doesn't affect serotonin. It affects more dopamine and norepinephrine. And now we have Auvelity, which is a medication that is affecting glutamate. in a whole different way compared to other medications that are available in an oral form. So we have these different medications that are out there now that we didn't have a few years ago that are helping with that symptom of anhedonia, which is a lingering symptom that often predicts relapse. And I often compare it to a simmering ember on a campfire. If you have a simmering ember on the campfire, you didn't put the campfire out, you leave that simmering ember with a puff of smoke, which is kind of like a stress in your life. That puff of smoke can just flare up the flames and off you go, and next thing you know, you have a big forest fire. So a simmering ember on a campfire can predict a forest fire. A simmering symptom such as anhedonia with depression, even though you're pretty well put the depression out, a little bit of stress can bring out some of those symptoms again, and you can have difficulty with the depression recurring. So it's something we've talked about for a long time. We noticed it way back in 1987, 1988 when Prozac or fluoxetine first came out. And that was a medication that worked wonderfully for a lot of people. It was tolerable. It was a serotonin medication, but it didn't help with that lingering difficulty with being able to take pleasure in things. So if somebody still had anhedonia as a symptom and they couldn't take pleasure in different activities, they were more likely to have what we called Prozac poop out, and it just didn't work for them over the course of a year or two, and they wondered why it quit working. Now, I was a consultant at the time with Lilly, who created Prozac, and Lilly at the time, their top researchers were saying, well, you just need to increase the dosage. Well, as we found out, that didn't help because it was a serotonin issue where if you increase serotonin, you indirectly decrease dopamine. If you indirectly decrease dopamine, you can have more difficulty with enjoyment, pleasure, and trying to get back to where you wanted to be before. Thanks for your email. Let's go to our next caller. Hello, Sharon. Welcome to Matters of the Mind. Well, Sharon, you wanted to know, is selective hearing a sign of a mental health disorder? I think we need to first kind of look back, Sharon, take a step back. What is a mental health disorder, right? A mental health disorder is where, due to certain clusters of symptoms, you are having difficulty getting things done in your life, and you're having trouble socializing, you're having trouble going to work, you're having trouble with relationships, you're having trouble concentrating, you're having trouble getting things done that you want to get done. And I would add to all of that, being able to take pleasure in your life. So if you have a cluster of symptoms that will cause you to have what we call functional impairment, that's a mental health condition. So in that case, Sharon, if selective hearing is a component of a condition that's causing you difficulty with getting things done that you'd like to do every day, yeah, that could be an issue. For instance, if you have selective hearing at the workplace and you're not listening to your boss, that's a problem. If you're having selective hearing in school and you're not hearing the assignments and you're not following the instructor, that's a problem. So if it's selective hearing, we want to see what's the nature of the selective hearing. So on top of the list could be a condition such as ADHD. People with attention deficit hyperactivity disorder also attention deficit disorder without hyperactivity. With those kind of symptoms, you basically by nature have decreased activity in the front part of the brain, the thinking part of the brain, the part of the brain that allows you to focus, and the left front part of the brain, called the dorsolateral prefrontal cortex, allows you to pay attention to things that aren't that interesting. So hey, if you kind of tune out from various conversations because they're not that interesting, well, your left prefrontal cortex here might not be working so well, and that could be a symptom of ADHD. And we treat ADHD by basically firing up the front part of the brain using medications not uncommonly, such as the stimulant medications or maybe some of the non-stimulant medications that are now available, because they also can indirectly increase dopamine transmission. So if you increase dopamine transmission in this left prefrontal cortex, also known as the left dorsolateral prefrontal cortex, that can help with focus and concentration. So that could help with selective hearing. Now there's another phenomenon that occurs out there, and that phenomenon is where men tend to have about 25% less norepinephrine projections coming from their locus ceruleus, which is down here on the brainstem, right down here. So the locus ceruleus will fire out all these little projections, and men tend to have about 20 to 25% less projections of norepinephrine. So symptomatically, that means that men will not notice things to the detail that women might. So there are differences between the brains of men and women, and that's one of them, where men might not pay attention to simple, subtle details in the environment and social cues that women might notice. And that's because, just from a physical standpoint, men don't have the norepinephrine projections that women might have. So that's why men might not be as prone to paying attention in some social situations, especially, and in various environmental situations. And that's at all ages. It does not make a difference whether it's younger men or older men. That could be a factor in itself. Thanks for your call, Sharon. Let's go to our next caller. Hello, Roger. Welcome to Matters of the Mind. Roger, you mentioned...
Yes,
Hello, Roger.
yes, I had some questions about melatonin.
Yeah.
Several people in our family have tried taking it, have nightmares with it. Several are on anxiety medications also. Is there a good substitute, over the counter or prescription, that would fill in for the melatonin?
Yeah, Roger, I would recommend melatonin mainly for one type of sleep problem, and that's where you're having trouble going to sleep, or you're jet lagged and you're trying to get to sleep, and you've gone from the East Coast to the West Coast, and you're going the other direction. You're going from West Coast to East Coast, and you're trying to get to sleep at a different time, and you're just not tired. And we see this a lot of time with adolescents, where adolescents will just have a hard time going to sleep. The adolescent brain naturally wants to stay up later and get up later the next morning. That's a normal factor with adolescents. We call that delayed circadian rhythm disturbance. And when that occurs, you can use melatonin safely for an adolescent, no more than 3 to 5 milligrams, I often recommend. Now, if a sleep medicine specialist tells you to take 10 or 15 milligrams at bedtime, hey, go ahead and do it. But generally, 3 to 5 milligrams is plenty for a lot of people. But the thing about melatonin, Roger, is it's like a puff of smoke. It's there for about 30 minutes, and it gives your brain the chemical signal to go to sleep, then it's gone. Melatonin naturally does come from the pineal gland, which is right smack in the middle of the brain here. And it's basically known as the vampire hormone because it goes up when it gets dark, and it goes down when it gets light. So if you have the darkness of the night, melatonin will go up and give your brain the chemical signal to go to sleep, and then it kind of will hook up with our circadian rhythms to try to get us to go to sleep at the same time every night. So the best thing you can do to get your melatonin regulated naturally, Roger, would be to try to go to bed the same time every night and try to get up about the same time every morning. That's what your brain wants to do. Okay, melatonin's not working for you, and melatonin, you bet, can give you nightmares if you take higher doses. That's why I don't recommend going up to 10 or 15 milligrams of melatonin because it can give you nightmares and actually worsen your sleep. So I'm always warning people, don't take more and more melatonin if it's not helping you. If it might not be helping me because it's not giving you the quality of sleep you want at the dosage you've been taking, and 3 to 5 milligrams at bedtime is usually plenty for a lot of people. So what are other options? Well, if you take diphenhydramine, also known as Benadryl, and diphenhydramine is an ingredient that's in a lot of sleep medication. It's an antihistamine that does tend to knock people out, makes them sleepy, but it gives them a dry mouth, and it makes their memory kind of foggy until noon the next day, especially if you're over 55 years young. So if you're as an older adult, you're going to have more trouble with Benadryl or diphenhydramine. I do not recommend that especially for older folks. Younger people, maybe adolescents, they can kind of get by with diphenhydramine or Benadryl, but that's not usually a highly recommended agent for people. Unisom is a trade name of a medication that contains doxylamine, another antihistamine. Again, kind of okay if you're going to use an antihistamine, but be very careful using it as an older adult. If I'm treating an older adult with specific difficulty with getting to sleep and staying asleep, I probably want to go with a prescription medication. There are some over-the-counter agents. Valerian root is over-the-counter. It's an herb, and it's really okay, very, very safe. You could try that, but in terms of something that works, I'm going to typically go with one of 3 things, not uncommonly, gabapentin being one. Gabapentin doesn't work for everybody, but it's a good medication for a lot of people. What I like about gabapentin, it's something that typically is not addictive unless you're using it with a narcotic. It will amplify the effect of a narcotic, not as much as Xanax, Klonopin, or Ativan, but don't use it with a narcotic, basically, is what I will recommend. I like gabapentin because it gives you a greater depth of sleep, so it gives you a deeper, better quality of sleep. It helps you dream in a good way without giving you nightmares, and it gets out of your system after about 8 hours. Works within 20 minutes, gets out of your system within 8 hours. It's an old anti-seizure medication that affects these little overactive calcium channels that supposedly keep you awake. A second medication would be trazodone, been around since 1982. Trazodone's been around for a long time. Trazodone's a medication that specifically will affect these serotonin receptors called serotonin 2A receptors. By blocking them, again, gives you a greater depth of sleep, helps give you a good quality of sleep. About 1 out of 19 people will get a stuffy nose on it, so they don't like it for that reason, but 18 out of 19 people don't get that effect. And a third treatment that we'll use as a prescription medication will be liquid doxepin concentrate. It comes in a tablet form called Silenor, but it's 3 to 6 milligrams of doxepin, a tiny dosage of doxepin, which used to be used as an antidepressant medication. Talk it over with your primary care clinician. There's a lot of options out there. Lack of sleep over the course of time is not a good symptom to experience. It can give you difficulty with high blood pressure, higher risk for diabetes, and even heart disease. Roger, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air, you can write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS Fort Wayne, now on YouTube. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.